And me. And we got Scotty from the crisis line. So today will be fun. You'll hear some more things kind of coming up regarding the digital health core and some other announcements regarding everything that's developing. But today I wanted to get into, because there's a lot of stuff here. There's going to be some fun stuff. For those that are in the room, take some coffee, have some of the food. And for those online, sorry, we'll catch you next time. We'll see what shakes out. Anyways, without further ado, I'll let Ursula introduce herself. We'll kind of go from there. Thanks.
Absolutely. All right, great. Hey, everybody. Good morning. Thanks for having me. I flew out of Seattle this morning at 5:40 in the morning just to hang out with you guys, so I really appreciate you having me here. My training is as a clinical psychologist. I trained at the University of Washington with a woman named Ursula Whiteside. So she developed a treatment that's called dialectical behavior therapy, and that treatment is one of the treatments that has the most effectiveness in terms of reducing psychiatric hospitalizations and self-injurious behavior, and largely among a group of people that were considered for a long time impossible to treat. So she made the magic happen. This is a photo of her hooding me, and this is when I had, so if you can see me, I have blonde hair. This is me with brown hair. But I moved to the University of Washington in 1999 to work with her, and I worked with her as an undergraduate and a graduate student until 2008, 2009, went on internship. And then I applied for some funding to adapt DBT skills and make them online. And you'll be hearing about that today. This is a public resource. It's called nowmattersnow.org. And that was funded by the National Institutes of Mental Health and the American Foundation for Suicide Prevention. So I got to hire Marcia as a consultant when I got those grants, which is really kind of, it was really nice. I'm going to show you a little of the experience of this public resource, the Now Matters Now website. And it is a website, it's not an app, and that was intentional. We wanted to start with a website that was mobile optimized, and to put our energies there, knowing things that people struggle with when they're building apps, that the reach of the app and the ability for people to find the most appropriate app for them is a real struggle. So you see here some of the different screens that people would work through on the website, and this website is entirely video-based, or almost entirely video-based, and what it includes are people with what's called lived experience, and we'll talk about that. So this is what the desktop experience looks like. You land at this page, and it asks you if you've had suicidal thoughts or problems that felt unsolvable. You are an excellent company, we've been there, and Now Matters Now Hack Suffering. So you click this button to go in and watch videos. And these are videos of people who've been suicidal, many of who've had suicide attempts and self-injurious behavior, talking about how they use strategies from that treatment, dialectical behavior therapy, to manage their intense emotions and their suicidal thoughts and urges. And it's sectioned into these bars where you learn about it, you learn about suicidal thoughts, you learn about mindfulness, which is a strategy from dialectical behavior therapy, but we all know strategy from many things. You learn about lethal means and opposite action. Actually use language that was used in the clinical world intentionally, and that's for another conversation. So this is, if you would say, go in and select opposite action, this is what you might see. You'd see a list of people, of names, and you choose a person's name and you watch their videos. And most of these are brief, between 30 seconds and 3 minutes, but then there are some that are quite long. We got Marcia Linehan to teach some of these videos herself, teaching the skills. The people with lived experience, they're talking about examples of how they use the strategies. So for those of you that are familiar with behavioral change strategies, one of the things that we know is most effective for change is social modeling. So seeing and hearing about how somebody has done this in their own life makes it easier to apply in your life. And that was one of the big things. Another reason for having people with lived experience tell these stories is that there's this idea of reducing stigma, that somebody talking openly about how they've coped and not acting with shame is a stigma intervention in itself. So there are a number of things. And then finally, because stories are so memorable, like didactics, are one thing, but storytelling is much more powerful. Like you may remember a little bit of what I tell you today, but if I tell you, hey, I've had suicidal thoughts myself, you're going to remember me, and you're going to remember that about the story because there's a story attached. And I have had that experience, and I talk openly about it. There's not a lot of people that talk openly as we have, kind of cross the researcher, the clinician, the trainer person who will talk openly across those. But it turns out about 10 million people in the United States seriously considered suicide in the past year, about 4%. So we should treat it like it's this thing that to be very afraid of, but by all estimates, less than 0.5% of people who seriously consider suicide in a given year will die by suicide. So we are surviving, and suicide is uncommon. That doesn't mean we don't take it seriously. It's just that I think particularly in healthcare, we sometimes freak out a little bit more than that is helpful, especially given this is such a big part of the human condition. Also, wanted to highlight here the crisis lines button. This on the landing page, and then also on this main page. And the reason that is important is because obviously we wanted people to know how to get help immediately. But also what we found it to be really interesting is that's how people found us. So the Now Matters Now website, it's intended to be strategies that people learn how to use over the long term. Like you acquire these coping strategies, these DBT strategies over time. You practice them, you hear about them. If you're in traditional dialectical behavior therapy, you go to a class once a week, you are there for 2 hours, you go home and you do homework, right? And this is intended more as exposure to these strategies and to get people thinking and understanding them. But it turned out a lot of people who are coming to us were finding us through, because we had listed an extensive group of crisis or text messaging resources. And that is how people were finding us. Took us a little while to figure that out. The other, a couple other things are the team. So I mentioned the people with lived experience. And initially what we wanted was for people to be able to kind of sort for who they wanted to hear their stories based on like whether they looked like them or they found their bio compelling. That was the original idea, and so this is how that played out. We have basically just a list of my team of people who with lived experience and a little bit about them. So you can scroll through, and we've got people who are very representative of different groups, and that's because they're fantastic and fabulous, and also because it's helpful to have variability. The cool thing, and I want you to consider this, and you're probably already doing this, but when you're applying for the research grants, what we did is we hired people to be, so our lived experience team were consultants, just in the same way Marsha Linehan was a consultant on my grant, right? And oh boy, that was interesting. So I worked in an organization that had never done suicide research this way, and they were very concerned that these are research subjects. And I said, no, they're experts, and they're our consultation team, and they're helping guide the development of this intervention. So, have somebody else do the hard thing first, and then so you can reference it and say it's been done already. And then you've got a More tab, and I'm including this mostly just so you know what additional resources are on this website. In the field of suicide prevention, and particularly in healthcare, we have been doing things all sorts of different ways. And what's coming down the pipe now is that there's these 3 interventions that are going to be the minimum standard of care. These came out in April. So it's a recommended standard care for patients at risk for suicide. And that was released by the National Action Alliance for Suicide Prevention. And basically what it boils down to is ask people whether they're suicide, and I'm talking about in healthcare, ask people whether they're suicide. Do something called safety planning, which is in some ways a very crappy name, but we've got it, which includes addressing people's preferred methods for suicide, we call lethal means. And then the third element is follow-up care and contacts. And I won't have time to get to that today, but that's a very interesting topic in itself. And people can download free caring contact cards from my website. There's a lot of evidence. Essentially, the short story around caring contacts or caring messages is that's one of the only things we know prevents suicide. Reducing people's access to lethal means, so putting time and space between them and their preferred method of suicide, and sending people non-demanding caring contacts, especially after they've been very suicidal. And those essentially are not, are you okay? Have you been taking your medication? No, they're not that. They're, I'm thinking about you and you're always welcome sort of message. So anyway, the website is intended to be a resource not only for people with lived experience coming here, but also a lot for clinicians. And there's some posters. Like, I really think one of the cool things about working with tech companies, like I work with Facebook to help redesign the end of their user experience for people who've been reported as suicidal. We just seeing, like, what are some of the things that are done outside of academia. And this is simple, but they would have posters when they're rolling out new products or initiatives. And so in healthcare, you know, everything falls to, you know, something's at the top of their consciousness for a little while, but there's so many things that things fall out of consciousness so easily. So we created, and this is entirely volunteer, I donated a lot of money to this, but we created just a bunch of posters that you can put up in your healthcare system that remind people of this website and of these resources. You know, down the road, what I really want is to be able to create a weekly video. So another way of keeping something at the top of somebody's consciousness, and I have some of these, I have a few, but they're called the Skill of the Week, and they're a video that's 2 to 3 minutes. That probably should only be a minute. But where there's always new content coming out, and that could be pushed via text, Facebook, you know, Instagram, whatever. And this is really just been a labor of love and just trying out different things. But again, with the idea, like, how do you get that to the top of the person's consciousness? It's like when you are being asked to donate money, it's like the more times they ask, the more likely you are to. It's just that repetition. So I mentioned this safety planning. It's one way to manage intense situations. So this is a safety plan that we've developed for this website. It's very busy. And because it's very busy, there's a guide. This is just a PDF that people can download from the website. And it's a guide that walks people through this safety plan, but it's focused around DBT skills and this metaphor of you have different strategies for approaching coping. You use different coping strategies depending on the situation. So if you are in an overwhelming suicidal crisis, what you do is going to be different than what you do to manage your day-to-day suicidal thoughts. Which is going to be different for what you do to help bring down your stress level in your life overall. So I call that this fire safety metaphor. You're on fire, in a fire, or fire prevention. Those are the approaches. And we'll talk a little bit more about these on-fire steps in a few minutes that I'm quite excited about and that are a little bit cavalier, probably. So fire prevention is just a little bit more of a close-up, but go ahead and go to the website, download those PDFs, and just so you have them and see what they look like. Anybody wants to send me feedback, say this sounds stupid, I think that this would look better and be communicated more clearly this way. If anyone has that user design expertise, you know, that would be great, but no pressure. So I'm going to give you just an overview of how things have been going on the website. We've done a little bit of advertising, but not much, and it was launched World Suicide Prevention Day in 2014. So we've had 250,000, 210 unique visitors, mostly people coming from organic search. Almost all of those are looking for crisis lines. That's how they find us. Any thoughts or questions so far? Okay. So we have a high bounce rate. People don't stay for very long, a minute and a half, but some people stay for quite a while. So since this website was launched, this public resource, we have about 7,000 visitors, 5,000 to 7,000 visitors a month, depending on whether we've been featured in something. We always had or almost from almost the very beginning, we had a quality improvement survey because we want to know who's visiting, not just Google Analytics, who's visiting, and are they finding it helpful at all. And then we applied for IRB approval to review that data and present that data. This is what the survey looks like, and we'll go into it in just a bit more detail. So I took a sample of people who filled out this survey. So you saw there's a number of visitors, but a sample of about 3,000 visitors who filled out the survey over 2 years and 9 months. Most people were not men ages 36 to 64. And the survey was delivered at different times. The reason I looked at 36 to 64 is because that's one of the highest risk groups for men. Men ages 36 to 64 are the highest risk groups for suicide. Not everybody knows that. So men are more likely to die by suicide. So this survey, it asks, when you entered this site, so this is retrospective, and again, it could come up after 1 minute, 3 minutes, or 8 minutes. When you entered this site, rate your suicidal thoughts from not at all to completely overwhelming, and actually not just your suicidal thoughts, rate the intensity of your emotions when you entered the site, and then your suicidal thoughts when you entered the site, and then rate them now, what level they are now. So intensity of negative emotions, intensity of suicidal thoughts. Turns out these things, I'm only going to talk about suicidal thoughts, but they're almost identical. It's just that people rate their negative emotions more high than they rate their suicidal thoughts, and some of the reductions we saw in intensity are greater for negative emotions than they are for suicidal thoughts. So again, when you entered the site, and then what about right now? I don't know how surveys are done on websites. I don't even know like all the methodological, I mean, I have some sense, but we just made this up. So what you see here are what we wanted to see. This is, we're not expecting people's lives to be overwhelmingly improved in any way in this website. But we also want to make sure it doesn't make people worse. So what we see is that of the people that rated their suicidal thoughts as not at all when they entered, which is blue, more people started to fall into that category for the now. So compared to when you entered to now, we saw this general shift from in the black moving down to the not at all. So people generally, they're shifting, their suicidal thoughts are getting less. People are moving from one category, from the completely overwhelming down to the less overwhelming, or in some cases not at all. So we saw a little reduction, about a 6% reduction in the intensity of people's suicidal thoughts. So they came in rating about a 3.15 and got down to more like a 2.95 probably. What I was particularly interested in were the people who are what I've called coming in hot. So people who were rating their suicidal thoughts as completely overwhelming or nearly completely overwhelming. And this is partly just common sense, but also because of the research that we've done at Kaiser, where we looked at over 1 million patient health questionnaires, and people who rated their suicidal thoughts, not the top band, the top two intensity, were much more likely to attempt suicide and die by suicide, which makes total sense. But I'm kind of finding the corollary here of who may be the people who are most at risk based on the similar data, or based on somewhat related data from depression questionnaires at Kaiser. Okay. So again, this is this group over here. Good news, people who, it's hard to get more suicidal than completely overwhelming suicidal thoughts, but in general, the number of people who rated their suicidal thoughts as completely overwhelming when they entered went down. And we had, so there were almost 50% of people who filled out the survey rated themselves as their suicidal thoughts as completely overwhelming or nearly completely overwhelming. Like, I'm finding a very hot sample, and which is sad that this opportunity for real intervention. And so we're seeing that, there are about 6% fewer who fall into that really hot category in the short time that they're on the website. It could be just that they're distracted, which we have a website under development called Meow Matters Meow. And, and you know, like there's something to be said for being distracted. It's one of the most effective tools when somebody's completely overwhelmingly upset, is distraction. So this could just be because it's time. It just could be distraction. Yes?
I think you kind of just answered my question.
Yeah.
I was wondering if you had any thoughts on sort of what's driving that decrease, because I know like actually working on decrease sales takes a lot of practice.
Yeah.
The time might not be immediately effective.
Yeah.
So what's kind of decreasing that?
Yeah. And that's like, if we can figure out how to answer that question, that'll be really helpful. But Meow Matters Meow is one because a lot of people I know really like cats, including myself, Sasha Fierce. And we wanted a place to put all our cat videos and photos and stuff. But also because I think that this might be a way to kind of compare. There's a distraction element of it. So don't look at the website right now because all the status. It just got bios, no videos yet. Unless you want to learn about all my colleagues' cats. Okay. And this is just the summary that includes negative emotions. Overall, what you're seeing is people are rating themselves as getting better. This could just be passing of time. But it also could be seeing people who look like them. It also could be finding something that appears non-judgmental. Also could be A, B, and C. So what about 50% of people, what do I do for these people that are coming in hot? I'm going to tell you what we've done so far. So this is Marsha Linehan's theory of emotion dysregulation. It's actually Linehan's theory, biopsychosocial theory of emotion dysregulation is the long term. But what it shows is essentially that in comparison to others, people in this blue group have a different experience when they come across a stressful event. But also you could think of this if you want to help it hang a little better, but think of yourself. When you've had a baby, you got a new job, you going through a divorce, whatever, hopefully not all at the same time, you respond differently when you're already under a lot of stress. But basically this says that some people live in the red zone, that when it's stressful, they're walking through their daily life and they're stressed, but they're only like at 17 or 18. And then a stressful event happens and they get more stressed and then they come back down over time. But for some people, their emotional baseline is higher. And then just think about you when you're already stressed, about how things affect you differently than when you're not as stressed. We respond to stress differently when we're already stressed. And so for some people, because of their biology, physiology, history, their response to stress is more rapid. They stay there for longer, and then they take longer to return to baseline. And in fact, they may have a stressful event that keeps them queued up over and over. And I call this high part being on fire. That you think about when you've been so upset, or the first time you had to deliver a talk to a group of people, it's a different state. And there are problems associated with an emotional intensity that are different than, with high emotional intensity that are different than low emotional intensity. People tend to have a full body physiological response. They make cognitive errors. They have some impaired processing. Like I'm sure I have forgotten some words. I've been talking this morning that is partly just due to stress, and there's a little bit of impairment in processing. Some people, when they're at this 80 out of 100, have a panic, overwhelming escape urges. And then sometimes for people there's a myopic focus. So their attention becomes very focused on one thing, could be a ruminative thought. And if that ruminative thought is about suicide and escape, it can be dangerous. So what we started to do is we said, okay, so we've got these people who are coming in hot to the website. And then at the same time, I was doing a qualitative study with suicide attempt survivors who had gone to a doctor's visit, got asked if they were suicidal. They said no. And then shortly after attempted suicide. So we're trying to understand what's this phenomena of people who don't say they don't have suicidal thoughts and then attempt shortly after. Is it that they weren't? Is it that they didn't want to tell their provider? It turned out with all of these people, except for one, it's a little bit unclear, they did not wake up that morning intending to die. So this is actually really important because when we think about suicide, we think about people making a plan, having intent. Most of these people decided to kill themselves within it and acted in about a 10-minute period. So we asked, and we thought these might be some people who are similar to those that are visiting our website, that they're feeling this intense of suicidal thoughts. So we asked researchers, mental health clinicians, and staff, and those with lived experience and suicide loss survivors, what are your recommendations for what we should do in this situation? And so we targeted each of these identified problems with a solution, so reducing emotional arousal as quickly as possible, redirecting people's attention away from this strong stimuli of suicide, explicitly telling people what not to do, and over-practicing. So we think of this essentially as stop, drop, and roll. So what you do when you're in a fire is very different than what you do when you're on fire. When you're in a fire, you get down on your hands and knees and you crawl out of the building. You try to get as little smoke inhalation. You get outside and you call 911, right? When you're on fire, there's no calling 911. There's no trying to get out of the building. You are just trying to extinguish the intense physiological, the pain, the fire. You're trying to remove the oxygen. So what's the corollary here? So what we came up with for potential interventions for what to do were ice water and sleep, which sounds a little bit counterintuitive, but ice water is one of the few things that we know reduces physiological arousal, heart rate, really, really rapidly. It affects your vagal nerve. It can elicit something called the mammalian dive reflex, and it is known to reduce emotional arousal and affect your vagal tone. So it essentially involves putting your face in ice water, and your heart rate will reduce very quickly. And then we came up with some other explicit instructions for what somebody should do when they're in this overwhelming state. So these are the instructions that we came up with. These are available on the website, but the third one, no important decision, so explicit instruction to not make an important decision, especially killing yourself. Never kill yourself when you're suicidal. And then making eye contact, because that eye contact is one of the strongest stimuli that we know of. It's such a strong stimuli. It's not easily done, but it's what we ask people to try and do. By the third step there, you're not calling 911 when you're at the first step. You might need to get your arousal down in order to even push those buttons. But by the third step, you might be also texting the crisis text line. Okay, so my question that I'm struggling with is how to test these steps on the Now Matters Now website. For now, what I have is that when people go to the crisis line page, which is where the hot people tend to fill their surveys out there, so we think that that's how they came in that way, if that makes any sense. We've added these instructions with a bit of medical advice that putting your body in ice water or your face in ice water, you want to be careful if you have a heart condition. But I always say if the alternative is suicide, I think it's okay to risk the heart condition. And there was the ice water challenge, and that was 17 million people who dumped ice water on their head. Nobody died, as far as we can tell, that was related to heart condition. So thank God for naturalistic experiments and for techies who made that possible. Okay, so that's where things are at. I'm going to stop here and see. I would love some thoughts, research ideas, errors that you can see. Thank you for being here.
We'll open up to the room, and while we're waiting, we can see if anybody online wants to chat.
Yeah.
Go from there. Anybody have any thoughts or questions?
I just have a question with regarding to self-medication. We know that many people are using substances to help themselves coping with bad feelings and also suicidal thoughts. And do you address this at all on the page? And is there also a section where you have maybe your advice for this kind of thing?
That would be fantastic, the second thing. And don't have a resource for that. And
Can you actually repeat it just to make sure everybody heard
yeah.
the question?
So the question was about, is there future direction for peer-to-peer advice on the website? And actually, that's where we refer people to the crisis text line. Now, they're not explicitly peer-to-peer, but there are a lot of people who have lived experience who communicate on the crisis text line. But that's probably not where it's best for us to spend our energy at this point. And then your other question was about substance abuse. And it turns out that that dialectical behavior therapy was also tested on people with opioid addiction and alcohol. And so there is evidence to suggest that these strategies also work for people who are struggling with substances. And if you look closely at this, it says direct advice for overwhelming urge to kill yourself or use opioids. So because craving and the intensity people have around craving is often similar to the intensity that people have related to emotions, we've also suggested this advice for that population, for people in that situation. And I'm finding as I'm supporting some implementation of this in primary care in rural areas, there's at least in this particular area, there's so much opioid and meth problem that this is one of the main things that they offer. They're always suicidal. I don't know, that's the sample. I don't know the data on that, but more broadly. But yeah, thank you.
Yeah, not only the interesting problems, but also in the positive effect of drugs that, for example, some people may report becoming less incidental after having used psychedelic drugs and stuff like that.
Yeah. So what about the people who feel less suicidal after using certain types of drugs, ketamine or psychedelic drugs like that? Man, there's all sorts of ways to reduce your emotional arousal, and if it's life or death, I'm all for it to get you through this period. Of course, unfortunately, ice water and ketamine aren't necessarily a long-term strategy for managing those experiences, but let's make people survive first, and then worry about that stuff. But yeah, thank you. Good question. Yeah.
All the resources.
Yeah.
On the website. My first impression when I see these three on the screen seems very directed, which is an approach that is a little counter to the approach of doing it. Sex science is more supportive and more empowering to the tech city where they're at. I'm wondering if you've collected any qualitative research on what that feels like to be a bit more strong and directed as to stopping the urge.
So Sky is talking about the instructions on this page of the website are very, very directive, and was it intentional that they were this directive, and what do we think about a different approach that would be actually similar to the other part of the website, which is like, hey, you might be interested in trying this. Here's like a bunch of different, and it was really intentional, and we and it actually came out of part of this. In addition to interviewing those suicide attempt survivors who said it happened in such a short period of time, was one of the person who volunteers on the project. He's like, it needs to be as brief as possible. It needs to be as simple as possible. I can't think clearly. You have to make it concrete. And I have had with, in working with Marcia Linehan and working with suicidal patients for so many years, it's that very directive advice when somebody's at an 80 out of 100 in terms of their emotional arousal. That's really important because they can only handle doing one thing. And if they're trying to figure out, do I want to do this or not? And then doing it, sometimes that's too much of a cognitive load. And so in the high-risk situation, it's very directive in the training. But it will come down to asking people what they think. And I haven't done that yet. So we're thinking about when people fill out the survey on this page, to then randomize them to like the usual, use the crisis text line or suicide prevention lifeline, or use the on fire steps with a kind of like a guide of it. But ideas for that are really helpful. What do you think?
Yeah, I mean they're very different like service delivery models.
Yeah.
You have to have a conversation with the person as with this is one dimensional.
Yeah.
I'd be really interested to hear what people's experience are to what I say, as well as how they internalize everything.
And I really appreciate it. So he's saying we want to know, like, what is people's experience really like? And I don't have that data, and I like completely on board with that approach. And then I'm also on board with the approach of when it's life or death, I'm going to be really directive about this. Like, these are not like your typical skills. This is when somebody's urges are completely overwhelming, which is not the typical. As far as the data I know, it's not the typical suicide prevention lifeline caller. That some people are having suicidal thoughts, but it's very unusual to have a person that's feels that they're completely overwhelming and making up. It's less typical. So they're also we would be careful not to just ask people in general. I think that would be an error for us to ask just the average person, what do you think about this? We need to ask the person who has the completely overwhelming experience. Or maybe you just put up 2 types of advice and see which people respond to better. Kind of high risk, but
Yeah, this has been great.
mm-hmm. Yeah. Yeah. Yeah, so that's the fantasy that this, like, if it were tested and it were shown to be successful, then this would be something that, because that's where people go. Like, all my lived experience, people say, you go to Google, you put it in, how do I kill myself, or I want to kill myself, or, and so, the question is this something that could pop up when people Google suicide in the same way that the PHQ-9 pops up when people Google depression? And that's the fantasy. Yeah, but I'm not connected with people in that area in Google at the same time. Yeah.
I'm curious about the group that sort of isn't having acute suicidal thoughts and might be thinking more like emotion management and skills. One thing that I find really kind of overwhelming about DBT is to sort of know where to start. I feel like what the front page looks like. Do you have any section kind of people who are just looking for start managing their emotions?
Yeah. I think that that we have like, what is this? And that's the extent of it right now. I think that could be, I think that's so critical, because people get to this website and they're like, what? I don't know what to do with this. Like, so there needs to be more help with understanding that. I agree. So yeah, this what is it? You go in and there's a video about, like, what is this? Like, what? Yeah. Same with under about, something similar to that. So the question was, is there, it's hard to know where to start in dialectical behavior therapy because it's so big. So for those of you who don't know, it's an enormous treatment. And, how do we guide people in that? Yeah.
And I was just curious, so I think when you were talking about talking to more directly, informed partnering with questions, I was curious about the decision not to have kind of
Yeah, so Meredith Sears is asking about what was the decision that went into video versus more text-based stuff. And I think what you're saying is, with these panels, would it be useful to have more text describing and explaining the content in general? Yeah, that was really intentional to have the social modeling piece of people telling stories and describing how they did it. And also with the idea that might be more engaging. I don't know the research on that either, but than text-based. So, yeah. Yeah, you have your hand raised.
Yeah, so I have a question. Stuff more general, and I'm not in this field. So
Yeah, good.
But in cognitive neuroscience, we are lucky to get like 30 to 50 participants in the study, and I saw that you have it was great to see that you have this main effect of intervention. And I was wondering whether you got a chance to drill down into this sample. You showed where the 50% of the sample was kind of suicidal.
Yeah.
And did you observe individual differences and find some subpopulations which are perhaps more or less amenable to?
So the question was, he's saying you got a lot of surveys. So this I took a sample of 3,500 surveys. So there's ongoing samples of sections of the survey. But among 3,500 survey completers, we were able to look at men ages 36 to 64, and then this is before we had more detailed analytics, and whether they were healthcare providers or not, because we thought that people might be visiting who were I was training a lot, and we thought that might be what was going on. And men had significant reductions in negative emotions and suicidal thoughts, but not the bar wasn't quite as steep. The bar wasn't quite as steep. And then for healthcare clinicians, as we expected, they had significant reductions in suicidal and negative emotions, but mental health practitioners, they didn't have reduction in suicidal thoughts, but they also came in really low on those. So as suspected, I believe we had healthcare providers visiting the website for educational purposes. It's one of the few places you can go that it has an organized bunch of videos about dialectical therapy. So they're just not that easily found. All right.
Well, thank you. So we can transition now to our next speaker. And Anthony, thank you again.
Thanks.